Good afternoon. I'm Dr. Spicher, the medical director here at St. Anne's, back with another update regarding COVID-19. I think by now everybody's pretty familiar with the idea of COVID-19, and I think it's less frightening and certainly something that we're all learning to live with. So I entitled this COVID-19, the new normal. So I think that's what we've got. So I'd like to talk a little bit about sort of where we are in the pandemic and what has happened since our last talk, give you some updates about the vaccine and treatments, and then also some updates regarding COVID specifically as it relates to senior living communities. So as you can see in this slide, COVID over the years comes in waves. It seems to happen mostly in the winter. It also happens with new variants. So the last peak there during last winter was the Omicron variant. But as you can see, we're starting to head up a little bit even this summer, and that's probably related to the new variants that we're seeing. So we'll talk a little bit more about that. Fortunately, in terms of deaths in the U.S., you can see that the peaks are going down rather than up like they did on the cases, which means that not as many people are dying from COVID when they get it as we saw earlier in the pandemic. Same is true in Pennsylvania. As you can see, the peaks are getting a little smaller. And our situation in Lancaster is similar to what we saw across the country, with a very high peak in the winter and then a tiny peak that we're experiencing now during the summer. In terms of local vaccination rates, Lancaster is a little bit behind the rest of the nation, but we're not doing too badly. 75% of folks in Lancaster over the age of 5 have at least one vaccine. 65% are fully vaccinated. The seniors, as is true across the country, are much more highly vaccinated, 94% in Lancaster County. However, we do have some work to do with regarding the boosters. Only about less than half of folks had even one booster in Lancaster up till now. One thing that is changing is the whole situation with the variants. You know, when COVID first started, we thought that probably the virus was not going to change a whole lot because other coronaviruses really didn't change, and over time they pretty much stayed the same. And I think the scientists have all been surprised by how much COVID has changed over time, how much it has mutated. In some ways, it's similar to what we see with the flu virus, which tends to change frequently, and that's why we get a different flu shot every year to match the mutation that happens each year. So as a result of these changes, some of our treatments are less effective, particularly monoclonal antibodies, which are very specific to a particular variant. So as the virus changes, the monoclonal antibodies don't work as well. Vaccines still work, but they're probably going to need to be tweaked a little bit as the mutations and the variants change. Things that continue to work are things like social distancing and wearing masks, things that we did at the beginning of the pandemic, so obviously those things are still helpful. What we've seen is about every year we've seen a new variant. So the first blue wave was what we call the Alpha variant, so that was the first year of the pandemic, and most of the COVID virus that we saw that year was Alpha, and then the second year was Delta. And the third year, starting into the third year, it's Omicron, so that's kind of where we are now, and there's some variants of Omicron that are showing up. But it's been kind of interesting that about once a year or so we see a major mutation and change in the virus. if you can think of the virus as having a family tree, we've got alpha is what we started with, and there's a few smaller ones which really didn't pan out and really didn't affect the population very much. Delta was the big one. That was the one that really caused the most morbidity and mortality across the country. And now we're experiencing Omicron and Omicron's variants. There's B1, B2, B4, B5. Those are the various subtypes of Omicron that we're dealing with currently. But COVID has really changed, and Omicron has really changed how we think about COVID. It's almost a different disease now than it was a year ago. It's much more infectious than when we were talking mostly about the Delta variant of Omicron. So it's much easier to catch. And it's people who have been infected in the past don't have the same amount of resistance to future infections as they did with Delta. And unfortunately, Omicron has presented a greater risk to seniors even than Delta did in terms of catching it and getting sick with it. In terms of how Omicron is different in terms of symptoms, it tends to have a shorter incubation period, so the time from contact until you get sick is shorter, maybe only 2 or 3 days rather than 5 to 7 days. Symptoms are more like a typical cold, sore throat, maybe some GI symptoms, much less in the way of respiratory symptoms. We're rarely seeing cough or very little cough. We're not seeing shortness of breath or chest pain. We're rarely seeing pneumonia. The current variants of COVID, the Omicron variants, don't seem to affect taste or smell, so we don't see that anymore. And generally, it tends to be a shorter course. So in some ways, it has changed pretty significantly in terms of what we saw last year. In terms of seniors, for a variety of reasons, Omicron has been more of a problem for seniors. That is, one of the issues is that the larger society really has pretty much given up on most of the COVID precautions in terms of social distancing and masking. That seems people have moved on from that. So there's a lot more of it circulating in the population. There's more opportunities to catch it. And it's just much more transmissible and much more infectious than the other variants. As well, the vaccines that seniors got earlier in the pandemic, some of that protection is starting to wear off. And so all these things add up and make the Omicron variant more of a problem for seniors. Seniors also are less likely to have antibodies from prior infections. If you look at who has antibodies and who's experienced COVID infections, it's largely children and younger people. Seniors less so because they're less out in the population, they're wearing their masks, they got vaccinated, so they are a little more vulnerable right now because they haven't been recently infected. In fact, if you look at the rate of death from COVID, it's actually higher during Omicron relative to what it was during Delta. So for seniors, Omicron is more of a problem actually than Delta was. Delta was really a problem for middle-aged folks. The good news is that the vaccines really work for seniors. So take some time to look at this slide, but this is a graph of the death rate from COVID over the last year, and that peak, of course, is the Omicron peak that we just went through this winter. And the difference between the folks who were vaccinated and boosted and unvaccinated, it's really a dramatic difference. So the good news is that even though seniors are more susceptible to Omicron and it causes more deaths, if they've been vaccinated, it's less of an issue. In terms of treatment for Omicron, the monoclonal antibodies, which were fairly widely used a year ago, really have lost their effectiveness because of the changes in the virus. So there's really only one monoclonal antibody now that works, and it's hard to get, and so it's not something we use very much anymore. The antiviral medications continue to work just as well for Omicron as they did for other variants. And the treatments that we use in the hospitals, they're still the same. In terms of the long-term side effects, this I think is going to be one of the long-lasting issues that we're going to have to deal with as a society regarding COVID. And that is the symptoms that persist after someone has had COVID and is no longer infectious but has ongoing symptoms. And these symptoms could be ongoing fatigue, brain fog, chest pain, tachycardia, cough, shortness of breath, just a variety of things that just hang on for months and months. And this is all something we're still learning about and don't have a lot of answers at this point yet. For some people, these things do go away after months, but for others, they haven't gone away yet, so we just don't know exactly who's going to recover. Up to 30% of people may get some long-term COVID symptoms after an infection. The thing that I think is interesting is that it's not necessarily just the people who get severe COVID that get long COVID. So if you look at people with long COVID, 75% of them were not hospitalized. So these were people that were not that sick that they needed to be in the hospital, but yet are suffering long-term consequences of having had the infection. And of course, we know that vaccination reduces the risk of these as well. Lest we forget about masks that we're all still wearing here and a few other places, they still work. And probably with Omicron, if you really want to be well protected, you probably should have a higher level mask like N95. So if you are somewhere where you're around someone who you know is positive, or if you're traveling, or you're in some situation where you have some concerns, large groups of people, it's probably a good idea to use an N95 rather than just a medical grade mask. Turns out that mask wearing is probably even more important with Omicron than the others, but unfortunately has largely fallen out of favor with the rest of society. So other than here, we're not seeing them being worn very many other places, here in the hospital. There's a lot of things that have happened with vaccines over the last year. As you're all aware, there are 3 different types of vaccines that have been approved by the FDA, the Pfizer, the J&J, and Moderna vaccines. They're widely available now. The Pfizer and Moderna vaccine should be, in the next few weeks, approved for children under 5. So that'll be quite a breakthrough when that happens. Up to this point, children under 5 still have not been able to be vaccinated. There's a new type of vaccine that got a recommendation for approval through the FDA. Hasn't been approved just yet, and that's the Novavax vaccine. We'll talk a little bit more about that. And Moderna has announced that they're coming out with a booster for the fall that is going to be covering the Omicron variant as well as the initial variant. So it'll be a two-valent vaccine. We take flu shots that cover 4 different variants of the flu. So perhaps this fall we'll be taking a COVID booster that covers 2 different variants of COVID vaccine virus. So again, it's evolving to look more like flu in that regard, that as it changes, the vaccines will have to change, and it may be that as time goes on, we'll just get our annual flu shot and our annual COVID vaccine. So the Novavax vaccine is a more traditional vaccine This is similar to the shingles vaccine, similar to other vaccines, whooping cough vaccine. It's made from a protein. So what gets injected in the vaccine is a protein particle, the spike protein particle. And there's also an adjuvant which sort of stimulates the immune system to make more antibodies against that protein. So this is very similar in technology to what we've already had. And it turns out that it works just as well as the mRNA vaccines, which we already have. And it's hoped that perhaps if there are folks that are still queasy about taking the mRNA vaccine, this might be something they'd be willing to do. So that should be getting FDA approval hopefully later this summer. The other advantage of this is it doesn't have a lot of storage requirements. It can just be stored in a refrigerator like the other traditional vaccines that we're used to. If we look at, again, just what has happened over the course of the pandemic with COVID deaths and who gets vaccinated and who decided not to get vaccinated, it really is dramatic. These are data from the CDC. You can see the line at the top is the death rate for folks who were unvaccinated. The line at the bottom, which is fairly flat, meaning a very low rate of death, was for those folks who were vaccinated. And they've even gone further where they actually look at geography. And as you might expect, because vaccination has become such a political issue, you know, counties that were largely Republican tend to have a higher death rate from COVID than counties that were largely Democratic. So it's just another point that goes to emphasize just how effective the vaccines were and continue to be. Studies have looked at sort of what, how many people died unnecessarily during the pandemic so far. You know, we passed the 1 million death from COVID mile marker just a little while ago. It's been estimated that maybe up to a third of those deaths could have been avoided had people been vaccinated. So, pretty significant numbers. If you look at just the effectiveness in terms of whether you get COVID or not, when they recently looked at this in March, folks who were unvaccinated had about twice the risk of getting COVID and about 10 times the risk of dying from COVID as compared to vaccinated folks. Despite this, there still is a lot of hesitancy and a lot of myths about why or why not to get vaccinated. And I don't know that at this point people's minds are really going to change, but that's where we are. These are some of the things I hear when I talk to my patients about getting vaccinated, that it's not safe, hasn't been tested. They're hoping that their natural immunity from the last time they had COVID protects them. So I think all that we can do is continue to try to encourage, and hopefully when people experience COVID or their family members go through with it, hopefully that will help them to change their minds as well. One of the concerns about vaccination early on had to do with pregnancy. Initially, the vaccine was not recommended for pregnant women because we just didn't have enough information about the effects of it. It's been widely studied now. There have been hundreds of thousands of pregnant women who have been followed through their pregnancy after vaccination, and women of childbearing age who were followed even before they got pregnant, and then what happened to the pregnancy. And there's been significant safety and efficacy, no increased risk of loss of pregnancy, no difference in fertility, no difference in, one of the concerns early on was that it might decrease the risk of being able to get pregnant, decrease the ability to get pregnant. That has not been borne out. We do know that women who are pregnant who get COVID have a greater risk both to themselves and to their baby as compared to women who are vaccinated and don't get COVID. So all the OBGYN and maternal and fetal medical organizations strongly recommend vaccination for young women who are thinking about or who are pregnant. In terms of breastfeeding, turns out that it's similar to the flu shot. Women who are breastfeeding and have been vaccinated can pass along some of those antibodies in their breast milk to the baby, so it actually helps protect the baby as well. So again, the lactation organizations strongly recommend vaccination for breastfeeding mothers. In terms of the booster, it definitely helps reduce the risk of getting COVID. Probably doesn't make a huge difference in terms of death rate because people who've already been vaccinated already see that improvement in terms of risk of dying from COVID. The protection is not real long, probably in the order of maybe 3 to 4 months. But the effect is greatest in seniors and those who reside in nursing facilities. So it's really important for our population here that we encourage as many people as possible to get boosted because the immunity tends to be more short-lived in seniors, as you might expect. In terms of treatments, not a lot of change here. We are starting to use Paxlovid on the outpatient side and also even for some of our residents here if they turn positive. And it has been shown to be quite effective at preventing people from getting sicker, needing to go to the hospital. The other antiviral medication we're really not using. It is not that effective, and Paxlovid is widely available, so it's not something we're using very much. As I mentioned before, the monoclonal antibodies just are not that useful anymore because they are so specific to the genetic shape and molecular shape of the virus, so that if the virus changes just a little bit, the antibodies don't match it and then they don't work. And so the antibodies have to be upgraded and changed to match what's happening with the variants. Right now there's only one that's effective and it's not very widely available. So it's something that we're just not using very much anymore. In terms of over-the-counter preventative and treatments for COVID, not a lot of new information here. There was a lot of interest in vitamin D early on as a preventative because we noticed that people who did worse with COVID had low vitamin D levels. But like a lot of other vitamin studies, probably that is more a reflection of their overall health than it is the effect of the vitamin. And so when they actually administered vitamin D, to COVID hospitalized patients, they didn't see any difference whether they got the vitamin D or not. So again, more research needs to be done as to whether COVID is really affected by vitamin D or not. Same is true of vitamin C and zinc. There was a lot of, early on there was a lot of interest and a lot of, I think, hope put on these over-the-counter remedies as a preventative. Again, when they actually did a randomized study where they gave placebo and vitamin D and zinc, they didn't really see a difference. And ivermectin still doesn't work. I'm not going to say anymore. COVID hospital treatments, they really are pretty much the same. We're still using the remdesivir. It's an antiviral medication. We also use this to help prevent people from getting sicker with COVID. So people who are just test positive but have risk factors and they're really not sick enough to be in the hospital, we can give them a short course of remdesivir to reduce the risk of getting sicker. We're using steroids in the form of dexamethasone to reduce the inflammation related with COVID, so it's something else we're still doing. This probably had more of an effect for the Delta variant of COVID, where there was a lot of COVID pneumonia. And then there's an anti-inflammatory called baricitinib, which we also use mostly for COVID pneumonia. In terms of natural immunity for folks who've had COVID already, it does confer some protection against getting reinfected as long as the virus doesn't change. But if the virus changes significantly, then having had an infection with a previous variant doesn't give you a lot of protection. We don't know for sure how long, maybe in the order of several months. I would say that in terms of risk, you're certainly further ahead to get a vaccine than you are to expose yourself to COVID, because you risk the mortality and morbidity of the infection. And we know that the protection from vaccination is much greater than that from just having had a previous infection. In terms of long-term care, early in the pandemic, you remember those days, COVID was horrible, and the majority of the folks who were dying from it were seniors. It's estimated that up to 10% of the entire ECF population over the last 2 years has died from COVID. Again, seniors are once again a little bit more susceptible to the Omicron variant, and so it's critically important that we make sure that everyone is vaccinated and boosted. But just to demonstrate sort of the effectiveness of the vaccine, if we look at a graph of the deaths from COVID in nursing homes, see how big that mountain is there in January of 21? That was before the vaccine. That was our experience, at the beginning of the pandemic, and then how that has really dropped off. And if you look at the number of cases, see how high the peak is when there are cases this past winter? But when you look at the deaths, look how low they are. And to me, that speaks of the benefit and the protection from the vaccinations of seniors in long-term care, and the fact that we understand how to treat it better. But I think that really speaks volumes when you see how significantly the death rate has gone down in the face of actually case numbers being higher. So here at St. Anne's, I think we've done a very good job of vaccinating our residents. We just need to keep on top of that. If we can keep people's immunity up, I think it's going to be less of an issue. We've had a couple of cases recently, but those folks have done well with it. And hopefully that will continue. So in summary, I would say it's a little bit different disease now. It's more infectious, it's more prevalent, but it's not as serious, certainly, if we've been vaccinated. And so we just need to continue encouraging vaccination because I think that has been what will keep us out of the hospital and keep us healthy. So I'll be happy to take any questions at this point, if you have them.